So everybody here knows that mental health problems are very common in children with epilepsy, much more common than in the general population. And we've just listed here some of the statistics around it. So ADHD 7 to 10 times more common in children with epilepsy, behavioural problems, etc. And there have been many, many studies showing this over the years. We know this, and we need to now address it in a more meaningful and useful way for our patients through the clinics. And the reasons that behavioural and cognitive problems are more common in children and young people with epilepsy are quite complex. And there's an interplay between biological and psychosocial issues. And we're going to hear later from Isabel Heyman, and I'm sure she will explain a little bit more about how these factors might interplay. We know that the quality of life of children with epilepsy and their parents is significantly lower than the general population. And we also know that if you have epilepsy in childhood, that as an adult, your psychosocial outcomes are poorer. Even in an epilepsy that one might regard as fairly straightforward, childhood absence epilepsy, we know that employment rates, suicide, alcohol addiction, and so on in adults are at much higher rates than the general population and other chronic health conditions. Now, we've been talking about this for a long time. There are people here who have been really championing this for a long time, and certainly that Frank Bizak's here and Isabel Heyman, both of whom have been really trying to, highlight this issue for many, many years. And at last, this is getting into some of the current policy through the mental health strategy, through Royal Colleges, ILAE, and various other organisations. And on a day-to-day basis, epilepsy networks are trying to work away at it. That's why we're all here today through the epilepsy networks. And in Scotland, we've included a quality standard in our recent quality standards that were published this year, saying it is vital that mental health needs are identified early and addressed appropriately. But how do we go about identifying these problems in our clinic? We've got a lot to deal with in our epilepsy clinics, 20 minutes for my return appointments, 30 minutes in the teenage clinic. There's a lot of stuff to get through in that time. So we often find it difficult to identify problems. They're often difficult to recognise in the early stages. And even when we do identify problems, what can we do? Well, we know that CAMHS services are very overstretched. In Edinburgh, the waiting list to get a choice appointment to see if you're going to get in the service is at least 12 weeks, and then sometimes a year to get an assessment and treatment appointment. So we felt that there would probably need to be a different way for us through the clinics to try and address that. And this led to the development of our project, and I'm going to hand over to Kirsten, Verity, who's my neuropsychology colleague, to talk a bit more about it.
So basically, in recognition of this problem, myself and Aisla and one of our colleagues, Jay Shetty, decided that we really wanted to try and move forward some sort of screening project to try and find out and map the mental health needs of this population coming through the clinics in Edinburgh RHSC. And so we approached Edinburgh Children's Hospital Charity, and we were very fortunate in that they were prepared to award us a grant for 2 years for a clinical psychologist for 2 days a week and an assistant psychologist for 2 days a week to actually start to think about how to screen for mental health difficulties in children and young people with epilepsy. Now, we're currently just going towards the end of our second year, and we're hoping to get funding. We are planning to get funding for a final year to finish off what we're doing. So what we're doing at the moment is we're screening all children who are coming into one epilepsy clinic that runs weekly. And basically, we're taking patients who fit particular inclusion criteria. It's ages 5 to 18, and not in learning disabilities, specialist educational provision, because we felt that that group would probably have had, but in order to get into that, their needs have been identified to a degree and they should be being monitored, and not on a CAMHS caseload, so children who weren't known to CAMHS. So in other words, the children who theoretically are fine, okay, are the children that we included, aged between 5 and 18. So the protocol is that they come in, and as they're waiting in the waiting room, not that they would ever wait for an appointment, Ailsa, as they're waiting in the waiting room, they fill in a questionnaire. Now, we piloted a number of questionnaires, but concluded that the Strengths and Difficulties questionnaire probably was the easiest to fill in, gave us the most relevant information, and was liked by the families, liked by the staff who were getting the information. And we used that in the PEDS-QL, which is a quality of life questionnaire. And we used this on every visit, so every time the families came in, the parent and or young person would complete a questionnaire. And while the family went to see the neurologist, the questionnaires would be scored by the psychologist who's in clinic or the assistant psychologist, and a rating would be given. And this would be fed back to the neurologist and the family. And on the back of the rating, that was going to give us an idea of what to do with this particular patient. So what's the rating? Well, we decided to make it easy for the medics. To make it really easy, we decided, and for the families, of course, actually, to communicate level of concern about the questionnaire results, we use traffic lights. So we have green for no concerns, amber for mild to moderate concerns, and red for significant concerns, basically. Now, just out of interest, I shouldn't even show you that slide, actually. Okay, so this is a population that, remember, not known to CAMHS, not out with mainstream, so not barn door, learning disability, special needs. So theoretically fine, not under anybody. I've kind of given it away a bit, haven't I? So this is how it looks, because I know you're going to ask how it looks. And remember, this is not a research project, okay? This is a screening methodology used in the clinic. But this is what we were finding. So broadly speaking, around about 35% of that population came into our red zone, if you like. About 12 came into amber, and just over half of them coming through were green. And remember, we're going to chart this. Each time they come in, they're going to do this questionnaire, so we can kind of monitor, are things staying the same? Are things getting worse? Are they getting better? And the pie chart below is just for reference how we would expect the general population to look in terms of red, amber, and green proportion. And very briefly, your purple graph shows you again kind of looking at the kind of significance of these emotional conduct problems, hyperactivity, and peer issues in that population. So you can see that although this is not a group who are known to have any specific learning difficulties that would mean that they're educated out with mainstream, and they're not known to CAMHS, actually it's a very vulnerable group still. So you can't go and screen without then being prepared to do something about it, obviously. So when you identify a need, you have to do something. So what we have developed and are continuing to develop this year and will continue to develop next year is a sort of pathway. So this is like a stepped care intervention pathway, depending on the level of concern identified at that screening point of screening. So basically we are doing as little as possible, but as much as necessary, I suppose, to try and meet some of those needs quickly. And what we have is for the amber group, we have fairly low grade. We've got maybe a little bit of information about particular issues that we've identified in the screening, so just some self-help material. We might give them information like we have a hospital self-management group, which is a chronic health conditions, young persons or children's group that's quite generic that they can refer themselves into. We might suggest that they contact one of our third sector organisations like Epilepsy Scotland, so we might give them a flyer, but we don't do very much. It's very much just passing information on to them. We're hoping also to maybe ask for consent to communicate maybe a little bit of information, just generic information with school. With the red group, however, it's a much more concerning group. This is a group that might fulfill criteria for CAMHS, or it might not. And obviously, the first thing we do is triage this group by discussing with the clinicians in detail what we need to do and what the concerns are, and should we be making a referral to CAMHS. But as we've heard, the waiting time can be very, very long. So what we have is we have a few other things to offer above and beyond self-help. And referral. We would maybe, rather than just suggesting that the family refer themselves to third sector, we might actually ask the family for consent to refer them, so we actually prompt them into those systems and use our resources out there in the community through charities and so on. We also link very closely with those resources to make sure that we are ratifying what they're doing and that they are connected to us. So we would, for example, we run parent workshops with Epilepsy Scotland. So we do a young person's, parents of young people in primary school age and parents in secondary school age, parents of children in secondary school age, just thinking about building parental confidence and coping skills for managing and helping their children. Because as we heard earlier, you know, the children are likely to turn to their families first for support and help, and the families are often a wee bit out to sea. And finally, we also offer for the teenage group, the PI group, which is a psychosocial intervention for young people in epilepsy. This is a group developed by my colleague in Glasgow, Professor Liam Doris, who's a neuropsychologist over there. It's been very well evidenced as being quite an effective intervention, 6 weekly sessions run between psychology and a specialist nurse, improving young people's self-confidence and knowledge about epilepsy and giving them the opportunity to share their experiences with others. So that's been really well done. Been really well received. Sorry, I'm looking across to Richard, waiting for that sign.
You're 11 and a half minutes.
Right, okay, sorry. Okay, so just skip through a few. Okay, obviously we're evaluating how this intervention is being received. Basically, the PI group, for example, is extremely well received. The young people coming into this were really, obviously they're in the high risk kind of group. They're not going to get anything from CAMHS in the near future, although they may be going through the process of waiting on a waiting list. But we were finding virtually no dropout, very good attendance, 100% felt more confident. This is an N of 9, by the way. We can run this group twice a year, basically, to fit in around the requirements of the service. Everybody decided to go on and join the local Epilepsy Scotland youth group. So at the end of the 6 weeks, they still had ongoing peer support, which has been really, really valuable. Clinicians like it. In particular, I'll draw your attention to number 3, electronic versions of the questionnaires would be helpful. Guess what the next step is going to be? We hope if we can get funding and work out how to do it from a tech point of view. I'm going to speak to George. Okay, so we're hoping to find a way of getting onto tablets. Young people and their parents can complete in clinic. Clinician types in a PIN code, it pings up a traffic light, it tells you where to go from there. You get the information from the shared drive, you can direct them to that there and then, and that is almost psychology hands-free at the point of entry. But we would still need psychologists on the ground to run the groups and so on for the actual intervention. And finally, it's something that we're hoping to use maybe in a more wide way around Scotland. Scottish Paediatric Epilepsy Network is interested in this and is very, very supportive in this. And we're hoping that we can generate more actual information about our data and disseminate that, publish that, and also thinking about whether or not there's other populations that we could be applying this kind of model to. I'm going to stop speaking now. Thank you very much.